And now, Unit 3, Topic 12, opiate agonists, antagonists, and a little bit about cannabinoids. I just want to point out in our objectives that while I do say that we want to discuss how opioid and cannabis misuse and regs can impact veterinary professional practice, we're really not going to go in depth on this again. I just wanted to point out that many of these substances that we're talking about are controlled by the Drug Enforcement Administration. Drugs to know, full opiate agonists. I'm sorry I left out the word opiate. Most of them are Schedule II by the Drug Enforcement Administration. Partial agonists depends on the drug and the state, actually. Our cannabinoids, well, that's a whole hot mess. Technically Schedule I by the Drug Enforcement Administration if the levels of the psychoactive constituent THC are above 0.3%, but it kind of depends upon which state you live in. So let's start out briefly. Our mini lecture 1 topic is really pathophysiology of pain. So we have these ascending pain pathways. In the blue box to the lower left, we see things like protons, heat, very, very cold, noxious cold, pressure chemicals, touch sensations are sensed by the tips of the neurons or peripheral neurons that transduce those signals into action potentials that go up into the spinal cord, usually the dorsal horn in most species, go up the contralateral side to activate centers in the brain. So nociception is that perception of the noxious stimuli that occurs in the very periphery. Pain is the emotional response to the stimuli. So we have these lightly myelinated A delta fibers that are going to rapidly relay signals and pinpoint where that sharp pain is. We call this rapid first pain. We also have C fibers, which are unmyelinated. They're slow. They regulate signals relating to burning or dull pain. This is second pain. So our myelinated A alpha fibers and A beta fibers normally rapidly relay non-noxious signals like a gentle touch. And this is why rubbing a boo-boo can make it not hurt as much, because it kind of overloads the signal transduction pathway and your brain can't tell the difference between that sharp A delta fiber from the A alpha, A beta. Anyway, another story for another day. Most primary afferents, again, are going to send their signals to the contralateral thalamus through the spinothalamic tract. From the thalamus, we're going to go to different areas of the brain, including the frontal lobe and species that have large frontal lobes in particular, to activate those effective emotional responses to pain. If we look more closely at the very, very peripheral end, our nociceptive neuron, the tips of our neurons, if you will, we have exposure to heat, chemicals, mechanical stimuli, again, are going to be transduced to an action potential that are carried to the brain. So if you look at the graphic in the lower left of that neural tip, we see TRPV1. It's a transient receptor potential vanilloid type 1 ion channel that can be activated by heat, but it can actually be activated by the hot peppers, capsaicin. So if you've ever eaten a super hot pepper jalapeno, that burning that you get, that's your TRPV1 receptors. The ASIC channel is an acid sensing inward channel activated by protons. We have P2X, which is a purinergic receptor activated by ATP. And we have voltage gated calcium channels. All of these things can cause depolarization of that nociceptive neuron that's going to transverse to the brain to process the pain signal. Now, above the neuron, we see where it says tissue damage. This is where histamine, prostaglandins, tumor necrosis factor alpha, interleukin, serotonin come in to create this chemical milieu that sensitizes those TRP and other nociceptive channels to the presence of signal. So when we have inflammation, when we have tissue damage, release of histamine, formation of prostaglandins, etc., those channels get sensitized to the signal so that we're more aware of a potentially noxious, painful stimuli that could cause harm. So pain, well, we don't like it. I mean, at least I don't like it. It's there for a reason. Most of the time, acute pain, put your hand in the fire, ow, your signal to pull the limb away from the thing that's causing harm. So there is a reason for it. It's just not very pleasant. So a little bit more about our TRP receptors. Again, they're going to transduce peripheral signals, nociceptive signals. TRPV1 is going to be important when we get to talking about cannabis, because cannabis can desensitize, some of the constituents in cannabis can desensitize the TRPV1 to help alleviate pain. In humans, we also have calcitonin gene-related peptide. Well, in many mammalian species, the CGRP is nociceptive. In humans, we've made actually antibodies against CGRP, and now we have CGRP receptor antagonists that we use to treat migraine headache. So many substances in nature work on these signals, and at the very end, I have an FYI slide that gives you a list of some substances that are going to be activators and or desensitizers of these TRP receptors. So we talked already about peripheral sensitization. Those primary afferent nociceptors also release polypeptide mediators like substance P, also known as neurokinin 1. We're going to talk about neurokinin 1 antagonists, meropitant, which is antiemetic because it works in the chemoreceptor trigger zone in dogs and cats, but it's also used for pain. So it's going to help desensitize to nociceptive signals. When we have cell damage, we're going to get more protons formed. We get an acidosis. It also is going to cause release of potassium. It's going to cause synthesis of prostaglandins and another pain producing group of substance known as the bradykinins. Substance P, as I said, also known as neurokinin 1, is going to also cause degranulation of the mast cell. So now we have rubor, tumor, calor, dolor, those 4 cardinal signs of inflammation: redness, swelling, pain, or heat, calor, and pain. We also, again, have the calcitonin gene-related peptide that is a vasodilator. When you have vasodilation, again, you can get a little bit of edema. CGRP is also going to increase sensitivity of the TRPV1s to increase pain nociception. So in this particular diagram at the top, I have it labeled from periphery. Towards the bottom of the graphic, I have it labeled to brain because I always get backwards on which direction the signal is going when I look at this particular graphic. I want the brain to be on the top. Anyway, the brain is on the bottom, but on our primary neuron, that's the one that's coming from the periphery, it's going to synapse in the spinal column. The signal gets transduced across that synapse, that synaptic gap, by a couple of different neurotransmitters, but the big one that we're interested in is glutamate. Glutamate goes across that synapse to activate on the postsynaptic fiber an AMPA, a glutamate to AMPA receptor. The glutamate AMPA receptor allows for influx of sodium. This is going to cause depolarization of that postsynaptic fiber. Once we get to a certain voltage in that postsynaptic fiber, it's going to cause a magnesium that's blocking the pore of the glutamate NMDA receptor to pop right off, and that allows for the influx of calcium and sodium. That influx of calcium and sodium causes a rapid rise in the voltage in that postsynaptic neuron that causes the body, that neuron, to upregulate expression of the AMPA receptors. So when we get these nociceptive signals, we get an increase in our ability to perceive the signal. And this is also important because calcium in that when we have all this neuronal activity, it causes what we're just going to say is excitotoxicity. It can cause neural damage, excitotoxicity. Anyway, we can change, our bodies can change, and with drugs we can poke at that presynaptic fiber to modulate some of these pain signals. So we see at the top there an alpha-2 receptor labeled norepinephrine, also activated by xylazine. Now xylazine is an emerging drug of abuse by humans, especially in the Philadelphia area, I guess. It's called tranq. Xylazine is added as an adulterant to fentanyl. So when people are abusing their fentanyl, we'll talk about fentanyl and reversal of opiates, but they use the xylazine to make the fentanyl, cheaper. And the xylazine is an alpha-2 agonist, so it causes bradycardia, hypotension. The thing about xylazine when they're injecting it subcutaneously is that it now is going to be an alpha-1 agonist. It is kind of promiscuous at the alpha-1 receptors. If you inject it into the skin, we get severe vasoconstriction and necrosis. So people are having amputations from adulteration of their opioids with xylazine. Anyway, one of our objectives that we were going to talk about how emerging abuse is impacting your lives as veterinary professionals. Xylazine may end up being a controlled substance simply because people, I'm sorry, in my opinion, are not the sharpest creatures on the planet. Anyway, GABA B receptors, baclofen, from what I understand, it's in humans, it's more of a muscle relaxant, but we can use it neuraxially, epidurally or spinal infusions to treat pain. Now, from what I understand, it's not as widely used because of toxicity issues in veterinary medicine. Our mu opioids can act here to hyperpolarize that presynaptic fiber, preventing an the action potential from the voltage change from getting high enough to allow the calcium to influx through those calcium channels. So mu opioid receptors work there. CB1 receptors are going to work there. Our calcitonin gene-related peptide and neurokinin 1 are going to sensitize our presynaptic neuron to increase the likelihood of glutamate being released. So we can use anti-CGRP agents, the blockers for human migraine treatment, but also, as I said, the meropitant, an antagonist at NK1 for mild visceral pain in canines, and it's also an antiemetic. Pharmacologically, we can also block those calcium channels, those voltage-gated calcium channels. The drug gabapentin, controlled substance in Tennessee, but not in some other states, is actually a blocker of that calcium channel. Moving across the synapse now towards the bottom of the slide, we're seeing our postsynaptic membrane. Our GABA-A chloride channel activators are going to cause hyperpolarization. However, our benzodiazepines like alprazolam, lorazepam are not really considered analgesic. They can reduce the nociceptive process to some degree, but not enough to truly be considered analgesic. Again, we see our alpha-2 adrenergic agonist here, xylazine, mu opioid receptors, and we do have NMDA antagonists, things like dextromethorphan. Yes, the DM and Robitussin, dextromethorphan, is an NMDA receptor antagonist, as is ketamine, the anesthetic ketamine, and then also the opioid methadone. And then on our postsynaptic voltage-gated calcium channels, gabapentin is also going to prevent opening of those calcium channels to blunt the action potential towards the brain. Processing and modulation, the secondary afferents are going to project through the thalamus to other targets, to our somatosensory cortex for discriminative aspects like, oh my gosh, how intense is this pain? What's the quality of this pain? Where is it located? Our limbic system, our emotional processing center for that effective response to pain. The amygdala and the nucleus accumbens is the negative of reward here. So it gives us an aversion. We want to get away from whatever's causing us the pain. And then our rostroventral medulla, our raphe nuclei, and our periaqueductal gray that innervates our locus coeruleus, the source of norepinephrine in our brain, are descending fibers from these areas, releasing either serotonin from the raphe innervated nuclei or norepinephrine, are probably going to kind of dampen down pain signaling. As we saw with peripheral sensitization from the prostaglandins, etc., we can also get sensitization in our brain, central sensitization. So again, to the left, we see our glial cells there, cyclooxygenase, increasing prostaglandin formation. We're going to have interleukins, tumor necrosis factor, brain-derived neurotropic factor, inducible nitric oxide, ATP, that can sensitize areas of our brains to go, wow, that signal is even more painful than it should be. So the terms for that include allodynia and hyperalgesia. And I like to say that neurons that fire together wire together. I mentioned that NMDA receptor, glutamate NMDA receptor activity increases expression of AMPA receptors. This is why our neurons that fire together wire together. The more pain signals that are coming through, the more likely often we are to sense that pain signal. So the term allodynia, which is represented by the space on the x-axis between the light blue line and the purple line, is where we have a perception of pain from a stimulus that really should not be noxious. So the purple line is our normal physiologic pain, and then the light blue line is the pathologic pain that happens when our neurons have wired together, so to speak. So allodynia, perception of pain from a normally non-noxious level of stimulus. Hyperalgesia is really the distance between the purple line and the light blue line, starting where we have a signal that's normally noxious and painful, but now in hyperalgesia, we have a heightened perception of pain. Okay, so we'll stop here and move on. Our next topic will be opiate agonists and antagonists.